In 1948, in January, I took impressions of this child on the waiting list. I don't think I've seen, even in all of my experience since, a tighter lower lip. Actually, her anteriors were in an overjet.
オーバージェットがこのようになっています。
But the molars are in class 1. All 6 of her lower front teeth were in a straight line. She was getting some recession in the lower incisor area. She was almost 13 years age, so she didn't have much growth left. She was selected to be treated by one of the members of our class, and I had made a note of it to Dr. Brody about the tightness of her lip. And so she was assigned to Dr. McGonagle, one of my classmates. Now, Dr. Brody had him strap up the case and put in a shield against the lower lip. 2 weeks later,
2週間経ちました。
this was an acrylic shield that was, I would say, maybe 5 millimeters in height, fixed onto the arch with a 022-028 gold edgewise wire. 2 weeks later, she came back and the whole appliance was embedded in the lip. It was so tight, it was all wrapped around the shield. And then went ahead and strapped the case up and finished it with intermaxillary elastics. I watched this case very carefully because I was very interested in it, and I later reported it in the literature. Now you can see what the old edgewise did to the rotation of the mandible here. It's very commonly what we would observe. And if we go through our 4-position analysis, you can see here that the mandible was rotated open. Point A wasn't changed. Maxillary teeth were brought back. And the reason for it was that that lip was so tight that the lower incisor didn't move. The changes were in the rest of the arch. So in position 4, you can see that the lip was strong enough to move all of the molars back, both first and second molars. But at the apex of the tooth here, in the middle of the tooth, it hardly moved at all. She ended up, even with the old edgewise, with this lower incisor behind the APO plane. So I went back and traced her then 4 years later, before I left the school, because I was so interested in the fact that the lower arch had been moved back, lower molars had been moved back, and class 2 elastics had been used to move the upper molars back. So the lip was so tight that it literally was strong enough to move all the teeth in the whole mouth. So all my life I've been interested here in all of these muscles right around this orbicularis that we discussed. But actually what it is within this complex right up here. It's not the mentalis, it's right up in here. In Spotholtz's textbook.
Whose textbook?
Spotholtz. German, an old German text. He has a drawing in which the muscles have been dissected away, and the drawing is from the inside. This is a picture looking from the bone out. He labels this then the quadratus labii inferioris. Here's the mentalis. But there's some slips coming across here, which he calls the incisivus labii inferioris. And the other thing is that in certain patients, these two quadratus inferioris will join at the midline, forming a common band, which comes right in here, together with the whole angular complex, which I call the angular complex, where all of these muscles come together right here. We have a choice in some of these patients. For instance, here's a patient that had a very tight lower lip. A patient had, a dentist had taken out one lower incisor, Intercisal angle of 188. That's past 180 degrees. Now, we were able in this patient, we took it from 188 down to 110.
188度でありましたものがその110度にまで持ってこれました。
Here's the intrusion of the lower and the torquing of the upper. When people talk about the possibilities of treatment, this is one of them. Despite that deep bite, you notice we treated him without rotation of the mandible at all. The fact is, if you want to know the truth, we closed just a little bit.
少し閉じたぐらいであります。
But there's the amount of tooth movement and correction of molars that we were able to make with no extra oral traction whatsoever. Now in him, this lip responded, and we didn't do a lip procedure on him. But I think that's rather remarkable. I've seen him 10 years after treatment, and with that torque in there, he's still stable. And you can see here then cuts made from the middle of, or through the external oblique ridge, mylohyoid, and you can see this shelf of bone here. Now here at the second molar, notice the amount of bone that's present right there. And you get the idea of why I'm trying to use this as an anchor. Here's the first molar in an adult, the second premolar. Notice that the first premolar sits almost immediately over the buccal plate here. Then notice here that the canine has very little bone on the labial. Notice how thick it is on the lingual. Here's another specimen on the other side. Look at that bone. That's as long as the crown is. The thickness of that bone is the length of the crown. Look at it. And here again is the second molar and then the first molar. And the premolars. And up here then the incisor. I think this is a very good demonstration of the amount of bone that we're dealing with. This is what I call the cybernetic circle of treatment planning. If you will notice, up the top of the clock here, in making decisions, the first aspect regards the behavior of the chin. Before you can determine what you want to do with the face, you have to have an idea where the chin's going to be. What I want to talk about here is treatment planning. As I tried to relate to you the other day, there's a tendency for people to analyze the upper arch first. I suppose it's due to the fact that the smile shows the upper teeth, and the patient's concern is straight upper front teeth. That's what's going to show in public. Now, in the young patient, literally everybody that was working in the field was jumping bites. Nobody had x-rays, particularly joint x-rays. Most orthodontists still don't, nor do they even try to trace a condyle. Right here's where orthodontics stops. SNA, SNB. Isn't that it? Now, when the mathostatics started then, people started doing a Ponce index in 1909. The idea was to take the teeth, measure the size of the teeth, and make them into a normal arch form. Therefore, the primary interest was working on the upper arch with the assumption that they could make the mandible grow and bring the lower jaw up to it, wherever it was. Now, this idea still prevailed at the time of the development of the edgewise system. So, at that time, orthodontic diagnosis and treatment planning was done on the basis of the molars. What must I do to get the molars in occlusion? And the anterior teeth simply had to fall wherever they had to in order to get the molars correct. So the diagnosis and the treatment planning were based on molar relationships. Now what Tweed did
次はツイートです。
was to shift this in the diagnosis and the treatment planning to the lower incisor. To many old-timers, this was an insult. But it was the result of the observations that had been made with the edgewise appliance.
だけどね、
What he did was to go back and take 4 bicuspids out at his own expense, and he retreated these patients that were horribly protrusive as a result of his early treatment.
で
So he gained a lot of followers. Now in the beginning he did not have cephalometrics either. So his objective was, with empiricism, to just upright the lower incisor over the symphysis and the mandibular plane. But he had high mandibular planes and low mandibular planes.
だけど
If you had a high mandibular plane and put the tooth out here, that wasn't satisfactory.
あの
If you had a low mandibular plane, this would put it too far back. So the next thing he did was to go up to the Frankfurt plane. Now the real problem with that was that the Frankfurt plane that he used was from the machine porion.
で、あの
And in the individual patient, that could vary a half an inch easy. So that was the first mistake. The second mistake he made was to talk about the angle of the tooth as an expression of its forward or backward position. I could have the same angle with a tooth that is distal on the symphysis and one that's mesial on the
では
symphysis.
その
So he measured it on the inside of the angle,
で
and in his thinking, I'm sure, he was measuring that vertically off of a 90-degree facial angle.
で
If we take a lower incisor and measure it from 90 degrees, 65 is 25 degrees off. Now, if the profile is exactly straight,
で、あの側方というのはそんなにまっすぐではない。
in an adult male with a 90-degree facial angle,
でも
65 would put the lower incisor in at 25 degrees to the facial plane. But he said he preferred 68, so that was 22 degrees. Now, I came along then,
で、まあそのうちに私も矯正をやるように
while
な
I
っ
was
て
still at Illinois,
で、まあ
and I started talking to Dr. Downs about relating the lower incisor to the APO plane.
で
Let me go back just 1 second.
ちょっと話を戻します。
Tweed said that you should not displace the apices of the lower incisor. In other words, you took the root wherever you found it, the tip of the root, and you could upright it,
でアップライトする。
but he dare not move it forward,
で
because that was what he had done with the edgewise, and now he saw it, the uncomplimentary aesthetic results, and he was fearful of stripping it due to the pressure of the lip. So this is still the fundamentals of the Tweed philosophy. So this meant then that they would start their diagnosis with the lower incisor over the symphysis
という
at the 65 degrees. Now Steiner came along,
で、それで次はスタイナーです。
and he came along with cephalometrics at the same time that Tweed was going with the lower incisor in the way that he had done it. Both of them agreed that the mandible, or the mandibular arch, should never be enlarged,
enlarged
expanded.
で、あの
In other words, it was taboo to increase arch length. You couldn't expand the canines and have them stay.
あの
So this meant that you couldn't expand anywhere in the arch.
え
And so they had just absolutely gotten themselves into the corner where expansion was a no-no.
ということから
Steiner came along and thought cephalometrically then, and this is in the 50s.
で、まあこ
I showed you the measurements of arch depth.
れで
As a review, what did I say? The normal was in a normal occlusion
で思い出していただけますでしょうか。ノーマルな場合、正常肛門の患者では、人で
the
は、
distance from the first molar mesial surface
つまりその
to
6
the
番
tip of
の
the incisor,
近親からそのセット
at least in the Caucasian,
まあ白人の例
23
で
to
申し上げ
24
ましたね。
millimeter. Extraction, 17 to 18 millimeter.
バーシス
Now the other unfortunate part of it was
でも
that he took the lower incisor that was the most forward to do his analysis, instead of selecting an incisor that would represent the mean of the 4 incisors.
でその4本
Now, another error was reinforced, in my opinion.
で題されたと言っていいと思います。
And this was the method of analysis of the lower incisor employed by Steiner,
これ
which is again back to B point. B point is an alveolar point,
B
plain and simple. I've never seen a B point out here and a lower incisor back here. When I retract the lower incisor, immediately, the labial plate goes right with the incisor. So very plain and simple, he was relating the lower incisor to itself. Every logic that I can bring to bear on this idea tells me that he was treating the lower incisor to where it was in the beginning.
つまり
Now, Steiner was one of my best friends, and he later rejected the B point. But most people don't know that, including the American Board of Orthodontics. He stood up at one of my classes
でスタイナー先生一度私どものクラスに来ていただきましたが、
15 years ago.
もう15
And he said that what he did at the time that he did it was an important step to get orthodontics using cephalometrics.
これ
But if he was a young man
ただその自分がもっと若かったら
in orthodontics today, he would be doing what Ricketts is doing.
ちょ
And he turned and put his hand on my shoulder and said, Rick, you can quote me on that.
で
So he had abandoned
ですからそのスタイナー自身も
the B point because he realized that it led to a whole great number of patients that were flattened out too much. Meanwhile, here I am sitting there at the University of Illinois,
まあ
right in this hotbed. Hotbed? A hotbed is a warm bed of fertilizer, chips, leaves, and
Yes.
all of it. It makes a mulch
肥料ですね。
for growing
Yes.
gardens.
Yes, I know.
You know?
Yes, I know.
You know how it gets hot?
ああ、そうか。肥料を入れるとそれがだんだん発酵して熱持ってくるんですね。
And it's all in a bed, in a
でベ
thing.
ッドでなくて
This is the hotbed.
それはいわゆるホットベッドという
Okay, that's where the term hotbed comes from.
まあ
Hotbed means where the's a lot of activity.
だからホットベッドというのはそれは発
A
酵した
lot of
りいろん
heat,
な
a lot of worms, a lot of bacteria, a lot of things, you know, where all of these leaves and
枯れ葉とか藁とか
debris and everything is becoming fertilizer now.
落ち葉とかなんかそういうの
There's another name for it.
も
What do we call it, Phil? When you make a mulch, when you put all the stuff
Compost.
in? Compost. Compost. That's what I'm trying to think of. It's a compost. Now, that's what we call a hotbed.
う
So,
堆肥のことで
okay. Meanwhile, Illinois was a hotbed. We had an accumulation of a dozen leading scholars in the field of dentistry.
つまり
So I was right in the middle of this hotbed.
ですから
I reasoned that the lower incisor had to be related to a reciprocal line, the APO plane.
私
In other words, Tweed wasn't relating it to the maxilla. He was relating it to the Frankfurt plane. He ignored the maxilla. At least Steiner had SNA,
少なくともスタイナーはその SNA を使いましたから
but SNA came first, didn't it?
でも SNA の方が先に
SNA, SNB.
それから SNA
And S and B represented alveolus here. So this is where the problem was.
で、まあ、これが
Now, if I have convexity in the face, and I have S and B back here, what must I do to harmonize
そしたらばそ
that
の
with
調
the
和
face?
するのはどういうふうに何をすべきかというと、
At least Steiner went through a series of slashes.
少なく
If
と
I
も
do this, I got to do this, I got to do this, got to do that. So he would,
解析をしていき
in
ま
this
した。
way, reduce it down to where maybe he could harmonize
ある
for
程
that
度
case.
の
So I just told him one day, I said, Cecil,
だから私も
why don't you just use APO?
APO を使ったらいいじゃないかと言ったの
You
で
got a
す。
line there.
でここにちゃんと APO の
Put the
線があ
lower
るんだから
incisor in,
で科学はそこに合わせてみたらどう
depending
ですか
upon what you can do with point A.
そ
So
れ
he
を
was
やったらいいじゃない
moving
かと。
in my direction. Because Downs had measured the upper incisor
ダウンズは上腕
to
二
the
段を
APO plane, but the emphasis was on the lower incisor in planning. Most all of us had gravitated to Tweed's idea,
ありますが、
which I think was correct.
それは正しいと思います。
The idea of planning on the lower incisor. I didn't argue with the idea, but I did take exception to how he was relating it, because he ignored the maxilla. I suppose he had the assumption that he could move the maxilla and bring the upper teeth to wherever the lower incisor dictated. Well, that's in the possibility range, but then it doesn't fit the PPF. Is it practical and is it feasible
だから
to subject every patient to that kind of vigorous treatment? Is it necessary for aesthetics? Is it necessary for the long-term stability of an occlusion?
ある
And is it necessary for the health of the occlusion?
ある
Because the teeth are subjected to a tremendous trauma and a lot of work and expense.
でまた
The dynamics and the long-range growth consideration was not there. So what did logic tell me? Like it or not, we have to make a forecast, a prediction, or an assumption, or an estimation of where the chin is going to be. So I spent a lot of time studying what happened to the chin during the course of treatment. And I didn't like what I saw.
でいろいろ調べましたけれどもあまりいいデータとは言えませんでした。
Because literally in all patients, the chin was going south. Now, if the patient was brachyfacial to begin with,
でそもそも患者がその単眼型ということであれば、
things didn't come out too bad.
まあ
But if it was retrognathic to start with, and it went that much more,
それがまたさらに下に落ちてきたとすると、
now you had a problem, aesthetically,
心理的にも良くないし、
functionally.
機能的にも望ましくありません。
So this was where I was now in 1950, 51, and 52.
で
I was a good friend of Lloyd DuBrul.
ですが
I haven't seen him for years, but I would like to go back and see him again.
もう
But at that time, he was doing his work in anthropology together with Sicher.
でした
And he wrote a little book, and it was called The Adaptive Chin.
アダプティブチン
The
で
Adaptive Chin.
アダプティブチンという本を書いたそうです、このデブルワークという人が。
In this, he discussed the development of the chin of man. Man is the only animal that has a chin. Monkeys don't have chins. They have what is called simian shells. The teeth are ahead of Pogonion.
ポゴニオンよりも前に歯が生えています。
They are truly double protrusing.
ダブル
Therefore, protrusion of the lower incisor does not mean that it's going to be lost with periodontal disease. If they did, many Orientals wouldn't have any teeth.
もし本当にそうだとしたらば、もう東洋人の多くの人は全く歯がなくなってしまうと思います。
So he was discussing the uprightness of the head,
垂直に立
the
てる
development of the joint,
話だとか、
and all the theories that were present in the literature with regard to the oral muscles. And it was my opinion then,
で
based on DuBrul's work, that Pogonion was a stable point.
ポゴニ
That this was actually a recession that was taking place in the denture. This was also consistent with Brody's ideas, in which the buccinator complex
でこの考えはそのブローディの考え方とも一致しております。
was the strap around the denture, and it inhibited the teeth as the jaws grew out. So with those two ideas, it seemed to me as though the Lawrence Sicher should be related to Pogonion. Now this was objected to by Downs, by Moore, by Steiner, and a lot of others. Because the opinion was that a button developed by apposition here rather than recession through here. So the APO plane was rejected by many people in the beginning. I said, no, I don't think so. I don't think that's the way it grows. Not based on Weidenreich's theory and the theories of DuBrul and several others.
他の方のもちろん研究からしても言えます。人類学的な研究から言えるわけです。
So that's where it set when I went to California in 1952. So I hung in there with the APO, setting up in the treatment plan this basic idea.
これがその基本的な話。
I remember so well DuBrul would, particularly on Mondays, I could expect something around 10, 10:30, 11 o'clock in the morning, a phone call.
必ず電話がかかってくるんです。
Coffee's on.